Bye.
Hello, welcome to Knock Knock Eye with me, your host, Dr. Glockenflecken, your one-stop shop for all things eyeball related. We got a couple nice little topics for you, little eyeball topics, a couple patients, one a mystery patient that's relatively low stakes. Yeah, I feel like I've done a couple of like really high, like the terrible, awful things. This is one of those kind of cool diagnoses that you can make, and it's all wrapped up very neatly and nicely, and the patient left with a diagnosis, and everyone was happy, and it was the vision's fine, and all that stuff. So we'll get to that a little bit later in the episode. But first, over the weekend, I was traveling, and I got to hang out with a few of my fellow ophthalmologists, and a couple of them are former or current residency program directors. And so I asked how interview season was going. And I've been out of the academic game for so long, and whenever I interviewed for residency, I have very fond memories of traveling to the programs. I went on, I think, 10 interviews, and you know the travel was one thing. Like it was expensive. This is before Uber existed. Oh my God, I'm getting old. But before Uber existed, so I had to get rent a car everywhere I went, do the flights, the hotels, all on my own dime. So I took out extra loans to pay for all of this. I don't know how much I spent on 10 interviews, but I mean, it had to have been $5,000 that I didn't have, that now, in factor in interest, it probably cost me like $20,000. So anyway, huge cost, but I do have very fond memories of those interviews. I remember my Iowa interview where I ended up for residency, and just getting to go on a tour. Having a resident drive me around, getting to like really talk to the residents, and like getting kind of an unfiltered view of what life is like there, what the program is like. So anyway, that's my framework, my baseline for where I'm coming at when it comes to like residency interviews. That was my experience. So I asked my friends, how's it going? And I asked about virtual interviews, because currently in ophthalmology, all interviews are virtual. Every single interview for everybody, all the programs. That's apparently not the case for all specialties right now. There are some specialties that are opening it up, and everybody's in person, I think. And then there are some programs or some specialties where they leave it up to the program. Like the program can decide, okay, we're just going to do virtual, or we're going to do in person, or we're going to do a combination of both. If you can't come in person, then you can do virtual. And so I was picking their brain, like, what do you think? Like, what should we do? Well, first of all, they had a problem with the idea of some programs offering in person and virtual, because that can introduce some bias. And I totally agree with that. Like, if you're a residency program doing interviews, you can't just leave it up to the interviewee to be like, oh, well, you can just come, because that there's got to be some bias built in to seeing someone in person, maybe forming a personal connection with them, looking them in the face, spending more time with them than during an interview, versus someone who you're just seeing virtually. Like that can't be. I'm actually shocked that there are some programs that do it that way, where they offer both in person, or you can do virtual. That seems ripe for bias and favoritism, and that has nothing to do with the ability of the applicant, or the resume, or the CV, or anything. So anyway, that's one thing. But then the issue of just virtual versus in-person interviews. So talking to them, it was really illuminating, because there's a very clear difference of opinion when it with the old guard versus the new guard. I guess whenever all their program directors get together and they chat, they have like conferences that's like just for like educators, and all the program directors show up. There's a very strong vocal contingent of program directors who are toward the end of their career, past the prime or tail end of it, who very strongly, vociferously, support in-person interviews. They're like, we got to go back to in-person interviews. And then there's the young folks, maybe the people that just started in the job of program director, or they're basically millennials or younger. And I don't know if anything younger than a millennial currently in that type of position. But anyway, my generation basically, who gravitate more toward virtual. They see the benefits of virtual. And so it's this interesting dynamic right now, this because a lot of these leadership positions are transitioning from this older generation, which includes, boomers and Gen X. And now those positions are starting to go more toward millennials, younger folks, as the older generation is slowing down, stepping down from those types of positions, heading into retirement. And so you're getting the sea change of ideas and of what an interview, among other things, what an interview should be like. And so I just created my own like personal list of pros and cons for virtual interviews, because it's an important topic, I actually, and something that's that really came up obviously with COVID, because prior to COVID, all residency interviews and med school interviews were in person. This is how it was. I believe. I think that's the case for the med school. Certainly for residency, all specialties, all programs, it was all in person. COVID totally changed that. Everybody went virtual, and now 2026, some people are starting to migrate back toward in person. Some people are staunchly pro virtual. So pros and cons. So one of the pros, the biggest pro I think for virtual interviews, is that it just is less money. I think back to all those loans that I took out. By the time I graduated residency, my loans have ballooned up to $320,000, which now is probably like median. I thought I was like on the upper scale, end of the scale. But now I've heard people is like 400,000 as the cost of education continues to go up. And so it's less money. And that's going to be even more of a consideration now that they're going to be capping student loans. Because now, if you ask a med student to do in-person interviews, they have to go on 8 to 10, maybe 12 interviews, and they have to pay all the expenses for that. Well, there's going to be more people that are having to go to private loans, which are more difficult, higher interests, a little bit more predatory. And so that's not ideal. And so that's a huge pro for keeping things virtual for people that don't make money. Med students, it's less money. You're saving these young people $20,000 or more by letting them just stay home to interview. All right, a con is what I talked about earlier. Just there's something to be said for the interviewee to be able to be at that program, to see the landscape, to see the town, to see the building, to see how people interact with each other. Also, you get the social events, which is when the residents show up and they really let their hair down, and you can get a good sense of, do these people really like each other here? Do they know how to have a good time whenever they're not on the clock? Do the residents care for one another? Does it seem like kind of a family atmosphere? Like that's all really valuable information that I think is harder to come across they can say those things in a virtual interview. Yeah, we're family. But until you see people interact with each other, you see the back and forth. you interact with people on tours or whatever, it's really hard to really get a sense of whether or not that's true. So that's a big con for virtual interviews, is that you just losing that in-person aspect and all the things that go with it. Pro, all right. You don't have to wear pants during your interview. It might be a small pro, but it's pro nonetheless. If you're careful about it, you got to position your camera appropriately, folks. But theoretically, you don't have to wear pants during an interview. Um, Con, and this is one that came up for the first time when I was talking with my friends over the weekend, is this idea of people using AI to assist them in answers during their interview. I never even thought that this was a thing, but it makes sense that someone would come up with this, and maybe it's just Chat GPT that they're using. But basically, the AI program, whatever it is listening to the conversation and is taking the questions that the interviewer is posing and then producing a response, that AI generated response. Which, if you do that, like that's disqualifying, right? You wouldn't get a job if your future employer knew that you were doing that during your interview and not coming up with your own answers. Like that's disqualifying. Like, you don't deserve the job if you're doing that. And it's becoming a bit of a problem. And so one of the people I was talking with said that they can start to tell when applicants are doing this, because they will ask the question, the interviewer, and the applicant will say some kind of filler response, like, "Oh, that's a really good question." Now, sometimes people do that just because they are literally trying to formulate their thoughts. Like, that's a great question. But then the applicant is like looking off camera. And now that's apparently that's kind of a tell that someone might be using AI. Now, that also frightens me a little bit hearing that, because like I could see myself coming up with an answer saying, "Oh, that's a great question," and then kind of looking away, kind of lost in thought. So now you might be in a situation where somebody might accuse you, the applicant, of using AI to come up with your answers, but in reality, you're not. You're just thinking and you're looking off camera. So I don't know. This is a tough one, right? Like, how do you tease that out? I mean, obviously, if someone sounds like they're giving like an AI answer, but then also people like prepare answers, and that's okay, because at least it's your own thoughts. You're coming up with the words yourself. Like, I had a kind of prepared answer when someone had tell me about yourself. Well, I'd say the same thing every time, and I at one point I had it written out. Like, this is what I'm going to say when I get asked that question, and that's okay to do. Obviously, it's not okay to use AI, but how do you tell the difference? I don't know. I do not envy people that do residency interviews these days because of these exact issues. So that's a potential con for virtual interviews. Pro, another big pro is just the time. The time I spent so much time during my fourth year, and it's not like fourth year is the most of med school is the most time intensive, grueling experience. Like, it's like running joke that, you know, oh, that you're not going to work that hard during fourth year. It's your last time off before the work really begins. Um, but also, it would be nice to, be able to be on a rotation, and on your lunch break, you can just go sit down for an interview. Like, people are able to, or what if you have kids in med school and you don't want to be away from your family that long? You could just go take a couple hours, do a virtual interview, go back to your life. It's such a huge time saver. And that's why I think that the time and the money consideration, honestly, that trumps the potential pros of doing an in-person interview. Out in person, it's great. There's some really wonderful things about it, but man, the time savings and the money savings, it's hard to beat that. Honestly, they just got to figure out this like AI thing. I don't know. That's scary. Don't do that, guy. Just come on, be cool, be professional. Like just struggle through an answer. That's okay. We've all been there. Like you're gonna be more human that way. Don't give the prepared AI answers during an interview. That's terrible. Come on. You're all smart people. You got into med school. You're gonna get into residency. You gotta, you're smart. You can do it. All right. All right. Let's take a break. We'll come back. We'll talk eyeball stuff.
I will.
Yeah.
I was thinking.
What were you thinking?
Well, it's New Year.
Uh-huh.
That's the perfect time to have a fresh new outlook.
Okay. What's on top of your mind?
I love eyelid mites now.
You?
Yeah.
Eyelid mites.
Mm-hmm. I was just thinking, since they're so common, I should be more accepting.
What made you change your mind?
Well, 1 out of every 12 adults has an overgrowth of mites.
Yes, that's true.
And I know that if they happen to overpopulate and cause Demodex blepharitis, there is a prescription eye drop treatment, so no need to stress.
I love hearing you talk about Demodex. Do you like eyeballs as much as you like Demodex?
No, just the mites.
I'll take what I can get. But you're right. And so, if you ever have itchy, irritated eyelids, just go see your eye doctor. They can examine your eyelids, check for crusties, what we call collarettes, those things that the mites leave behind.
Sounds like a good plan to me.
To learn more about eyelid mites and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. Okay, I've got two case presentations for you. They're both pieces of it are made up, but the diagnoses this first one is something that I came across very recently within the past week. So this was a 25-year-old woman who comes in after noticing some swelling of the upper eyelid and a little bit of discomfort, a little bit of pain. And so she comes in, I do my exam. Vision's great. No prior eye history, which is very typical for a 25-year-old. I think myopia, that's it. So all she's had was glasses during her life, contacts. And so I did my exam, normal vision, normal pressure, pupils, everything's great. Get the old slit lamp out, put the patient up to the slit lamp, and I see a blocked oil gland in the upper eyelid, along with some swelling of the upper eyelid. And I say, I think I know what this is, and I have my confident face on because I was like, I know this is it. It's like, this is a chalazion. It's a sty. And then she asked me something else. She's like, okay, well, why is there hair growing out of it? It's like, what are you talking about? That means you have hair you have like eyelashes. But those aren't like growing out of your meibomian glands. I was like saying all of this, like very, confident. I'm the doctor. I know all this stuff. She's like, no, there's on the inside of my eyelid, there's hair growing out of it. And so I pulled up the upper eyelid, and what pops down is this ball that has hair. There's like 5 or 6 lashes. They look like eyelashes, just strand like hair follicles growing out of this mass. And as I felt kind of stupid, I was like, oh, well, turns out you have two things. Two things are here. So there was a sty for sure, but that's actually not the reason the patient had made the appointment. Patient made the appointment because they were worried because and trying to figure out what was wrong with their eyelid, they pulled it up and this patient found this mass that's not visible from the outside. You can't see because it's relatively small, with hair growing out of it, and was rightfully concerned. And so I was like, oh, and normally the kind of the thing with in medicine in general is that you don't want to try to make like 2 diagnoses. You want to try to all of the patient's like constellation of symptoms, whatever they may be, you want to try to like figure out one diagnosis that explains everything, because that's much more likely than someone having two separate things happening simultaneously. That's not typical. But this is a situation where, this patient actually does have two things at the same time. Now, the sty that had just come up within the past couple of days, but the tumor, the mass, that had been there most likely all her life, and just never noticed it. And so the diagnosis for this, do you know what it is? I'm asking you as if you're going to respond to me. I knew exactly what this was. This was a dermoid cyst. So let's talk about dermoid cysts. A dermoid cyst is a congenital, what's called choristoma. So it's a choristoma is a fancy term that means a benign tumor that consists of histologically normal cells. So epithelial cells, it's all normal stuff, as opposed to like a malignant tumor, which would be abnormal cells, right? These are histologically totally normal, healthy cells, but they occur in an abnormal location. So the cells are normal, they're just not supposed to be in that part of the body. And this tumor that I found was what the patient found and told me about it, was up underneath the eyelid. So normally you don't have hair up there. So dermoid cysts consist of keratinized epithelium. So that's what causes the cystic appearance. There's stuff that fills this ball, this tumor. Keratinized epithelium, and then also adnexal structures such as hair follicles, sweat glands, sebaceous glands. You can sweat out of this thing. And certainly the hair follicles, and that's what tipped me off to what this is. One thing, which was the hair follicles, where hair follicles are not supposed to be, and also the location. Classically, for a dermoid cyst that involves the eye, it's usually going to be the superior temporal, kind of on the outside of the upper eyelid, underneath the eyebrow. Dermoid cysts, they slowly get larger as you get older, up until adulthood, and then they can actually get a little bit smaller. But they are one of the most common orbital tumors in children. About 46% of childhood orbital tumors are dermoid cysts. Again, totally benign. All right, so you don't have to worry about this. And they do make up about 3 to 9% of all orbital masses when you take into account kids, adults. So a large, relative percentage of orbital masses, but still fairly uncommon to see these. And the reason these come up is because when you have these fetal suture lines that basically your face just comes together through these little suture lines. So when you look at a skull, you can see this like the old suture lines where everything kind of just came together. And sometimes you get a piece of tissue that gets like kind of trapped. You get some tissue that's cells, not tissue, but epithelial cells that get trapped and form this cyst. The diagnosis of these is relatively easy. Like for me, all it took, pull up the eyelid, there it is. So the location again, and those adnexal structures, seeing hair where hair shouldn't be. Now, usually when this presents in kids, it's this non-tender. That's a key point too. It's non-tender. It's mobile, and it's important sometimes in kids to diagnose this though, because sometimes it can cause a malposition of the eye itself. So thinking about where this cyst is, it's right underneath the upper eyelid most of the time. And if it gets big enough, it can start to push the eye. And if it pushes the eye out of alignment, then a kid can get double vision, can start to ignore the vision in that eye. And that's how you end up with amblyopia, or a lazy eye, where the eye doesn't develop normal vision. So that's why this is an important diagnosis to make if it comes up. But again, not a malignant tumor. So it's that nothing about this is life-threatening, but it can be vision-threatening on the affected side. And so once you've diagnosed it, in kids at least, you want to get imaging of this thing because it might be present from the front, but it could extend posteriorly quite a bit. So if you're having to do surgical planning to remove it, you need to get a CT to see how far back it goes. So, or an MRI. MRI works well as without the radiation risk to kids as well. So that's important to do for treatment planning. Other things it could be, you can get a cyst of your lacrimal gland. That's right where your lacrimal gland is. So I would never do this surgery. This is an oculoplastics type of thing. And so this is outside my area of expertise. I don't want to muck up around the lacrimal gland because then you could get severe dry eye if you disrupt the duct that produces your tears. So other surgical issues you need to consider there. But the reason for that you'd want to do surgery again, if you're having that globe displacement, double vision, but also, cosmetically it's another good reason because these are young people, right? And that's has to be a concern. Prognosis is excellent. You have surgery, remove it. Everything looks fine. You can't even tell. Oftentimes that type of surgery, the incision is hid in the eyebrow, which works really well on hiding incisions. And so kind of a cool diagnosis. And so I was able to tell this patient, oh, you have a dermoid cyst. This is I may even use the term choristoma. I got to impress someone with my vocabulary the other day. So yeah, there you go. That's a dermoid cyst. All right, I got one more little patient presentation for you. And let me know if you have any follow-up questions about dermoid cysts. Leave them in the comments on the YouTube channel at Glaucomfleckens. I like seeing you guys' reaction to these like mystery cases that I present to you. All right, let's take one more quick break. Okay, the next patient is a patient I received the call on call. This was probably about 6 months ago. And a patient that had gone to urgent care for a sudden vision loss. That was the report I received. Sudden vision loss, left eye in a 78-year-old. And so I hear more about it. This was during the day, fortunately. So I was like, okay, like send the patient. There's like, could this be a stroke? Should we send this patient over to the emergency room for a stroke workup? I was like, well, hold on a second. We don't totally know what this is. All I have right now is that the vision's lost, a sudden vision loss. It could be a stroke, right? If you send an embolic source, some kind of embolus up to one of the vessels in the eye, yeah, that can cause sudden massive vision loss. So my interest is piqued at this point. I'm like, okay, this could be something, but it's also, relatively convenient for me to just go ahead and see this patient rather than and make sure it's someone that does need to go to the emergency room before we actually send them over. So I was like, all right, I'll meet this patient in my clinic. So I come in, I think it was on a Saturday, and I meet the patient at the clinic. I bring them in and check the vision. Vision is 20/40 in the good eye, the right eye. Left eye was maybe 2400, but mostly like count fingers. So quite a bit worse. And then I get out my trusty pen light to do a pupil exam. Very important in something like this. When you have one eye, the vision is really poor compared to the other eye. Pupils. You got to check pupils because that will give you a very good indication of whether or not there's been a CRAO or even a BRAO or an ischemic optic neuropathy. Basically, anything stroke-like that might need to go emergently to the emergency department, you will see an RAPD, an afferent pupillary defect. So I did my pupil exam, and guess what? Stone cold normal. Totally normal pupil exam. So now I'm kind of like, interesting. All right. So we got poor vision. And I asked the patient, I was like, is this vision is much worse than it was before you lost vision? And she's like, well, yeah, I think so. Kind of unclear. But the pupils were normal. So now I know that the optic nerve is fine and most of the retina is fine. In order to get an RAPD, you have to have damage to one or both of those things. And so I went ahead and dilated the eye. And when I dilated the eye, uh, I took another look at the slit lamp, and the right eye, again, looks normal. Had some cataract, though. 78-year-olds typically have some cataract. So I had about a 2+ nuclear sclerosis. That's just the way we describe cataract. I look at the left eye, also 2+ nuclear sclerosis, but also 4+ posterior subcapsular cataract that was not present in the other eye. So this is a specific type of cataract that can come about for a variety of different reasons. We might not even know why a patient gets something like this, but diabetes is one of them. It could be people that use a lot of, oral or topical steroids can get this type of cataract. But it has a tendency to cause a dramatic amount of vision loss relatively quickly. Not like within a day, but certainly within months. And everything else looked totally fine. The retina was fine. The optic nerve was fine. This was the only thing wrong with this patient. And so I told this patient, I was like, I think I know what's causing your vision loss. And it's cataract. You need cataract surgery. Something that we can do as an outpatient, not an emergency. Your vision's going to be fine. You're going to see just fine. And so then the question is, well, but this was sudden vision loss. And you just said these cataracts, they don't come up overnight. This patient noticed it like that. Well, that's exactly what happened. The patient had a sudden realization of chronic vision loss. This is a very interesting thing that I learned in residency and that I've seen a handful of times over the years, in that obviously we're always looking with both eyes open at all times. But sometimes people will close one eye, maybe they rub their eye or they rub the other eye. And for a brief second, they have occluded their good eye and are looking with their bad eye and have a sudden realization that they have lost vision. This is a thing that happens. You might think, well, how is that even possible? How do you just not know that you've gone from 20/30 vision down to count fingers vision? It happens. You don't realize it. And that might be because that person is so dominant in their other eye that they don't even notice that they're starting to lose vision in their fellow eye until they close their good eye and actually try to look at things with the bad eye and realize, oh man, something is going on. Sudden realization of a cataract is like a legit thing that happens to people. And so much better outcome than a stroke, than an ischemic optic neuropathy, right? Because this is something easy to treat. I love doing cataract surgery. Everyone's happy because the vision's better. Patient was pretty nearsighted too, which is another reason that cataracts can develop pretty quickly. And so I brought that patient down to plano vision, no glasses. Everyone's happy. It was great. It was a great thing. I was like, those are the kind of calls I like to get on when I'm on call, because it's like I can just reassure the patient. Patient was terrified. Like, am I having a stroke? What's going on, doc? No, you just suddenly realized that you have a cataract, and it happens. So there you go. Add that to your differential. Now, the urgent care did the right thing. Urgent care did exactly the right thing in being concerned about something very serious like a stroke and calling me, who's on call for that area. And honestly, nobody would have faulted that person for also sending that patient to the emergency room before contacting me. I'm glad they contacted me first. But it would have been reasonable, because that's a scary thing. But what would have saved that person from making that decision would be being able to recognize an abnormal pupil exam, an afferent pupillary defect. So that's why I always encourage people who see eye problems in urgent care, emergency medicine, know what that looks like. There's a great YouTube video. If you just Google relative afferent pupillary defect, you'll find a great example of a swinging flashlight test that allows you to diagnose an RAPD, which indicates damage to the optic nerve and or the retina. And you see that in eye strokes. And if I saw that, I would have sent the patient directly over to the emergency room for a stroke workup, because if you can send an embolus to the eye, you can send it to the brain. And that's what you don't want, is to have an eye stroke and then a subsequent like ischemic stroke in the brain. So, but nope, sudden realization of a cataract. That was the diagnosis. All right. That's it for Knock Knock Eye for today. Thank you all for listening. I'm your host, Dr. Glaucom-Flecken, also known as Will Flannery in my day job. And thanks to my executive producers, Aaron Corney, Rob Goldman, and Shanti Burke. Our editor and engineer is Jason Partizo. Our music is by Omer Benzvi. Knock Knock Eye is a human content production. We'll see you next time, everyone.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.